Untold Physio Stories is part of the all-new PT Podcast Network. Find a new favorite podcast by an amazing PT content creator at ptpodcastnetwork.com. The future of medical documentation is here, and it's revolutionizing the way we record patient visits. Introducing Comprehend PT, the groundbreaking HIPAA-compliant AI scribe designed specifically for physical therapists. Imagine a world where the dialogue between PTs and patients is interpreted by AI into precise, real-time medical notes without lifting a pen or tapping a keyboard. Comprehend PT does just that, allowing healthcare professionals to stay engaged with patients rather than buried in documentation. Boost your efficiency, reduce claim denials, and liberate yourself from the burdens of manual note-taking with Comprehend PT. Join the revolution now at comprehendpt.com. Untold Physio Stories listeners get 50% off their first month with code MMT50, and there's a free trial available. Sign up now. I use it every day in the clinic for virtual and live visits. I just speak to the patient, and at the end, hit Comprehend, and a SOAP note's generated. I love it, and you will too. Welcome to Untold Physio Stories podcast, your perfect commute resource with physio failures, successes, interesting cases, and more from the physio and rehab world, with your hosts, Drs. Andrew Rothschild and Erson Religioso. Welcome back to Untold Physio Stories podcast. I'm one of your hosts, Dr. E with Modern Manual Therapy, Edge Mobility System, and our 4-month online mentoring program, Modern Rehab Mastery. My co-host, Dr. Andrew Rothschild, is not with me today, but I have a very special guest, Dr. Steve Goostree. Can you do a quick intro and talk to me, Goose? I'm sure you get that a lot. Do you get talk to me, Goose, a lot?
Clever, Erson. Yeah, I like that. So Dr. Steve Goostree here, just recently kind of branched out on my own after 15 years of in the trenches. Been a fanboy.
15 years already.
I was a PTA first, so I think that counts, right? Because I did a lot of counseling, and I took my first MDT course as a part A with my first con ed ever back in 2009, I think. So, but always been a fanboy. We met in Boston in 2012, I believe, and I was out east doing my DPT there. It was kind of a bridge program at the time, but I think I don't know if we were lab partners or something. But like, hey, I know you. You're the manual therapist, so I thought that was super cool.
Aren't you like 8 feet tall or something?
I'm like 6'4". So
yeah, I remember taking a picture with you.
Obviously, guys are going to exaggerate, so I think I'm actually like 6'3", but you always got to add up. Plus
well, I'm 5'7", so I mean, to me, anything over 6 foot seems pretty tall.
Respect.
Yeah. All right. Yeah. Well, I mean, it's great to have like known you when you were a student, and now you're forming your own practice. So, but you do have a story for us, right?
I do, and yeah, just right before I get to that, it's a very interesting fellowship story, which I'm sure you have a bunch of horror stories from that too, because that's a very challenging thing to go through. But I want to give you an apology and preface this by saying I just ordered the Edge mobility tool and what is it, the active? What is that?
The Active Force 2.
Yeah, so I just switched by all my banking, and so there's a whole debacle there. So apologies in advance for that, but I'm super pumped to try all that stuff out. I've been using your Edge tool for the last decade, the same one. So that thing is
the same one. Well, I don't even know if I have one that's 10 years old.
Well, there you go. There's
in the archive somewhere, but not in my practice. Those things they leave the practice like chips. And we used to have I like donated 5 to my old business partner, and finally I'm like, you're gonna have to start paying for these things because people keep on like walking out with them like they're pens.
Right. I think I insured that thing. I'm not even sure, but so let me get to this story. So this was you remember in your fellowship, and I'm pretty sure it's standard operating procedure now, but it was a live exam, and it was my very first one. I was maybe 3 months into the program. Shout out to Carol Courtney at Northwestern. She was my, still a huge mentor in my opinion. But yeah, so I'm getting ready. My mentor at the time, plus Carol Courtney, were in the room. We're in a small private treatment room, and I was sweating bullets. And I'm usually very cool, calm, collected. And the patient comes in. I was trying to do as much history, take it anything to my advantage at the time, right? So patient comes in, 40-year-old female, left or right, lateral hip pain was her chief complaint. So I'm like, oh, this is golden. It's probably already greater trochanteric, whatever, pain syndrome. So I'm like, this is going to be awesome. I'm going to be such a stud, right? So do a very solid subjective. They take me out into the hallway. I got a breather. They're like, what are your top 5 hypotheses? What's going on? So this is, I wasn't really thinking medically looking back on it, or even pain dominance at that time, because I was still pretty new. So I'm like, this is either a lumbar spine referral or GTPS, whatever. I'm like, I'm going to roll out the spine, then go to this, then give her a sweet loading program and look like a stud. So too long didn't read. What got through the subjective, got through the objective, and I was scratching my head, and I could tell the patient was noticing that I was getting a bit flustered. And I was looking over at Carol and whoever else the other mentor was at the time. And they're
Wait, hold on. I have a quick question.
Yeah.
Are these actual patients or mock patients that are acting?
These are actual patients that got placed on my schedule by the scheduling team. So I had no clue.
Okay. So we only had mock. We didn't have like an actual real thing that we had to figure out.
No, Carol doesn't mess around. So, I had no clue. That's why I was even Googling this person. I'm like, I saw their name maybe, that morning, and within an hour they showed up. So that was, number one, check, they're here. That's great. The mentors are here. Let's go. So I thought I was doing a solid job, and they're jotting down a ton of notes. I'm trying to make casual eye contact with them. They're stone cold poker face, right? So then I'm like, this is an automatic fail, and whatever, I'm accepting that. So did my objective, could not find any concordant sign whatsoever. So I was getting frustrated. I could tell the patient was, so whatever. So it's a manual therapy fellowship, right? So you want to find a concordant sign, test, retest, do a manual intervention, test, retest. So I did just a general long axis distraction, traction, whatever you want to call it, graded mode for Mulligan, or not Mulligan, Maitland. Constantly R1, R2, P1, all that good stuff. No effect, no changes, but her functional baseline was just over like SFMA deep squat. So okay, cool, I got that. Got her off the table, no effect. Please lie down. Did a thrust traction manip. Let's retract your squat. Nothing. So I'm ready to quit, right? So then she's like, oh, maybe I should have shared this with you when you were asking me all those questions, but I have MS. And my jaw dropped, and I looked at Carol, and I think the other mentor dropped her pen. And I'm just like, well, that would have been a little helpful when I was asking you all those questions. There was a method to my madness, so there's that. So long story short, I remember this patient because she made fun of my khakis. I'm 6'4", and I had some really baggy khakis on, and she told me I looked gaudy or gawky or something. So that one definitely sticks out in my brain.
That's funny. Well, yeah, I mean, this is one of those things where I learned to ask, is there anything else you want to tell me that I didn't ask, or anything that you think is not relevant, but there's anything else going on medically either now or in the past? Because people are like, yeah, I had very similar hip pain, and they're like, oh yeah, you know what? I remembered like 2 visits in where she's not getting better. I remembered like falling down the stairs and landing on that hip.
Right.
No, and then
that's where, if I could do it over again, I did a little bit more of a deep dive. Like that's an excellent tip.
Right. Yeah. Well, yeah, that's pretty scary. Did you pass though, or did you fail?
So I passed. I think we all high-fived each other once the patient left the clinic, and she came back. I treated her maybe 8 visits over a 2-month period because that's my MO. I'm not going to see you 6, whatever visits for 6 weeks. That's shameful and fraudulent. But besides the case, So she was like a lifelong patient. I haven't heard from her in a while, but maybe I'll reach out to her now. We'll see.
Awesome. Yeah, that's great. I had another hip patient who also was like only intermittently better, and every once in a while they were just like every morning they were worse, but throughout the day they were just overall better with the like side glides and the lateral and posterior chain stuff I was giving them. And they're like, you know what, I figured out that like my garage door always sticks open, and every time I like a garage like physical door, not like the car door, but like the door you go in and out of as a person, it like always sticks open because the frame is warped. So every morning when I'm going to work, I slam it shut with my hips, which is like a reverse thrust of the side glides that were making her better. So I was like, okay, I want you to kick it now instead. And when she was kicking it, then it just everything else like clicked into place, because that was the thing that made her worse in the morning.
That's super cool. And from your experience, we've both done the MVP training. Do you, and pain is at a one, so this is just a random question for you, from my experience, but do you think, when you ruled out the spine, or maybe it is a spinal derangement, do you think gliding toward or away is more effective, or it just depends? It depends, right?
Well, I mean, I would say the majority of the time it's going to be towards, just because most people are going away, and as a novel stimulus, it's more novel to load rather than unload, because most people feel tightness or perception of tightness on the involved side. Then they go to various practitioners, whether it's a standard manual therapist or a massage therapist. Everyone says you're tight, and all they ever do is gap and stretch. The average person, according to McKenzie stats, already unloads their spine thousands of times a day. Then they go to like unload it even more once they get stretched. So it seems like, I mean, even when I got certified in 2004, McKenzie had said he had never seen an anterior derangement, even though he knew they existed as a concept. I know some of his faculty did, but that's why it's more rare, because on average people just flex all day, and they very rarely extend, or they very rarely load. They're always unloading, but they don't load too often. And I've seen several anterior derangements, but they're still way more rare than posterior derangements.
Absolutely. And that's one of my favorite, if it's even a nociceptive, nociplastic, peripheral neuropathic, you name it. I love seeing that chronic, persistent human with, neck or even any spinal complaints, but they've been told by, a variety of providers that, you need to, your left upper trap is tight. You got to stretch away. And then just the simple retraction.
Right, then you go toward, and it's just like magic, right? Yeah.
And they're like, why didn't anyone else tell me this? It's like, it's like, keep it simple, Steve, the KISS method, right? Like, it's so simple. I don't know.
For those of you who listen frequently, and you haven't either taken my courses or just standard McKenzie courses, I always want to ask, every time I see someone on social media and they're talking about like how difficult a case is, or just any case in general, I'm like, what do you do when you don't do repeated end range loading? I mean, just like, you got to temper expectations, and you look at all these clinical practice guidelines, like this always takes like 4 to 6 months, and this takes 6 months, and this takes 8 months, and I'm like, not if you're doing it right.
Right. I feel like that needs to be part of all entry-level DPT, residency, and fellowship training. Is how simple is it to do a repeated movement exam with your PIVMs, neurodynamics, etc.
Right. Well, it's also reliable. I mean, there's like,
you can't out research MDT. That's just a proven fact, especially for the lumbar spine, right?
For sure. Hey, you know what though? Are we specifically talking about MDT in this podcast?
No, we're talking
not
about
not in the print. We're talking about a particular method that is very reliable, and it might improve your outcomes dramatically.
That's correct. We're calling it a reset here between you and I.
Yes, for sure. End range loading resets.
Right. No
with directional preference. That according to the directional preference. All right.
No TM.
Yeah. Hey, Goose. Where can people find you?
Yeah, so brand new. I used to be that guy that posted on my personal Instagram once a year. So this has been, definitely a behavior change. But yeah, you can find me on Instagram at Dr. Stephen Goostree. Same if you want to email me, drstephengoostrea@gmail.com, or my website, drstephengoostrea.com. Keep it simple, Steve.
Yes, that is a simple brand, and it's Goose with no E after the S. There are 2 E's, but it's part of the tree.
Correct. When I was a kid, I remember asking my dad, I'm like, hey, can I just start adding a C after the Goose, because it was just such a common typo? He's like, absolutely not. Be proud of that name. And I am. Here we are.
Yeah, you should be. I used to want to change my first name to Scott, because everyone got my name wrong, and I like the name Scott.
I feel like Scott's kind of a wicked bro, no?
Yeah, Scott Relioso. It doesn't sound right.
No, that's a tongue twister.
Sorry, Dr. E does sound better than Dr. S.
Yeah, that's why Dr. Goose sounds kind of cool, I think.
It does. Yeah. All right. Well, it was great reconnecting, and I'm pretty sure you'll be on again, because I know you have a couple more stories. So, hey, if you like Dr. Goostree's story, or you have any similar stories, have any comments or questions, make sure you reach out on social media to either one of us. Make sure you hit that subscribe button wherever you listen to podcasts, Apple, Spotify, Google. And as always, you guys have a great day.
Thanks, Erson.